Ontario's healthcare system has been battered by COVID-19. Medical staff have been pushed to their limits for sure. And there's a massive backlog of diagnostic and surgical procedures built up as a result of shutdowns during the pandemic that some worry will never get sorted out. It's been floated before, even as recently as in the federal election campaign. Should provinces consider looking to the private sector for help tackling the healthcare crunch? Well, let's get into that with, in London, UK, Alistair McGuire. He's the head of the Department of Health Policy at the London School of Economics. In our nation's capital, Colleen Flood, professor at the University of Ottawa and a university research chair in health law and policy. And in the annex neighbourhood of the provincial capital, Sara Allin, assistant professor at the University of Toronto's Dalla Lana School of Public Health and the Institute of Health Policy, Management and Evaluation. And we're grateful to have all three of you with us on TVO tonight. I want to start by just outlining the nature of the problem we're facing here. And these are numbers from Ontario's Financial Accountability Officer. That is a neutral office, nonpartisan, responsible to reporting to the legislature. So these numbers are, as they say, not torqued. These are numbers from March of this year, and it shows the estimated cumulative backlog of elective surgeries thanks to COVID-19. And for those listening on podcast, I'll just describe this. If you go back to March of 2020, when the pandemic began, we had fewer than 50,000 cases in the surgical backlog. But then as the months proceed, suddenly we're up to 250,000 by March of 2021. And the forecast for the future is to be well beyond 419,000 as we go forward. So this is an enormous backlog that, as we suggested in the intro, some are wondering if we're ever going to get out of. Question one, Colleen Flood, to you first. Is our healthcare system, as it's currently constituted, remotely capable of dealing with that backlog in a timely fashion?
Well, I think so. We will have a challenge, no doubt, to respond to it. But whatever our problem is, we have X number of doctors and X number of nurses. That's not easily corrected in a really short time frame. So it's going to come down to adroit management of this, and I'm hopeful that with the rise of virtual care as well, that this will help. Now, I'm not saying it's not going to be a big challenge. Of course it is.
All right, I'm going to repeat the question for Sara because, again, the key words here are, can we get through this backlog? People waiting for elective surgeries, they're waiting for diagnostic tests for cancer, that kind of thing. Can we get through that in a timely fashion?
I don't think it's going to be an easy feat. And what I'm hopeful is that this pandemic may provide that shock that we've all faced. That's actually a window of opportunity for major change. And we've known for decades that we have a major problem with wait times in Canada, and we haven't been able to address this. Now that the problem is bigger, it's more pressing. We saw the numbers. So I'm hopeful that we can kickstart major reform that will actually address this longstanding problem, and COVID may provide that opportunity.
Well, one of the things we want to discuss, and the reason that Alistair is on the program tonight, is that Canada is supposedly a single-tier healthcare system, meaning people of better means are not able to buy their way to the front of the queue. In the United Kingdom, they have a somewhat different system. And Alistair, I wonder if you could help us understand how your system works there in a way that might help alleviate the backlog if you had it over there, the likes of which we have here.
Well, there's some similarities. For example, I think there's very good reasons why we wouldn't rely on public health insurance, for example, fully. I think that any healthcare system is best funded primarily by public finance, through public finance. The problem with public finance is, of course, that you've got budget constraints, and you face budget constraints, which means normally for publicly financed systems, we don't really have the capacity to easily adapt to shocks like COVID. So we have capacity constraints. We even have capacity constraints, waiting times for elective surgery, for example, without COVID happening because of these budget constraints. But in the UK, we also have a complementary 13% of the population holding private health insurance rather, and that takes some of the pressure off the public sector.
Let me just follow up on that because I want to make sure our viewers understand that. The NHS, the National Health Service in the UK, basically 88% of all the procedures done go through the publicly funded system. And as you just indicated, you got about 12% that use a parallel private system. What is the effect that having that 12% in the parallel private system on the public system?
So it's about 88% of expenditure through the NHS and 12% expenditure through the private sector. So it's not exactly the volume, it's the expenditure. But the question still stands. The public sector is facing widespread constraints. They have constrained theatre times, for example. And one of the ideas is that the private sector alleviates those pressures and therefore alleviates the pressures on the public sector NHS waiting times. Very difficult to prove that. It's difficult to prove it for a couple of reasons, but the main reason is if you have a private sector, it may alleviate some of the public sector constraints, but also demand for healthcare grows anyway. So you get a growth in healthcare because of the public sector moving into the private sector, but you also have alleviation of the public sector itself. So waiting times in the public sector may be lower than they would have been otherwise, but it's really difficult to prove that.
All right, let's get some feedback then from our Canadian guest. Colleen Flood, is there any evidence that you know of whereby if we introduced that type of model into Canada, whereby there were a private option and a parallel system to Medicare, that it might take some of the pressure off Medicare and make things better for both systems?
So recently we had a big court case that evaluated this question. 880 pages of analysis by Justice Stevens looking at expert witness testimony about it and concluded, that there wasn't any such evidence. So I think we've had a good thrashing of this again. The problem is, as I mentioned in my opening comment, is that we only have X number of doctors and X number of nurses, and they will only, already now we are feeling shortages in the public sector. So, we know that if we create a parallel private tier where the work is probably easier and higher paid, and perhaps then you can stay in downtown Toronto, downtown Vancouver, Montreal, that we will exacerbate, in my view, our existing problems. But I completely agree with Sara that, that in and of itself is no reason to rest on our laurels. And, what happens is we sort of fall into these old, tired debates about public and private. Those of us who support a public healthcare system are constantly sort of fighting this battle instead of rolling up our sleeves and figuring out how the hell to fix wait times for everyone going forward. And there are possible solutions out there, and we really need to grab hold of them and beat folks around the ears at the political level to make it happen.
Okay, let me go over to Sara then and get her take on whether or not you believe the British-style offering of a second tier is an option for Canada that might help alleviate the backlogs.
Well, I agree with the previous speakers that there is no evidence, no strong evidence that a parallel private option would alleviate these wait times. And in fact, the detailed studies of the UK showed that wait times were brought down through a mix of, massive increase in funding, public funding, setting of really aggressive targets, so setting limits for wait times, similar to what Quebec has done recently to try and, address the problem within the public system. And no credit really was given in the UK to the private parallel tier. when they were successful in reducing wait times. So I think there are lessons that we can draw from many countries, but that doesn't seem to be one for many reasons. And I'm hoping we'll get into some of them that why it might not work in Canada either.
Well, let me just check with Colleen. Is it the Brian Day case? Is that the one you were just referring to, the court case?
Yeah, Brian, well, the applicant is Canby Surgical Services, which is the private clinic, and Dr. Day is the sort of main proprietor.
Okay. Well, we just happen to have a witness for the defendant in that case, the Brian Day decision in British Columbia. So, Alistair, I wonder if you could just give us a sense about what that case was about and what you testified to in that case.
So I wasn't a witness for the defendant. You're actually an expert for the court, so it's independent evidence, although it was Canby Surgery who called me to be an expert. But that aside, essentially it was a case about elective surgery, and the idea was that in the current setup, all Canadian provinces actually are meant to, if you're a medic or a healthcare provider and you contract with the public funder, you're only meant to take publicly funded patients. That leads to constraints, obviously, because the budgets are constrained. And because the budgets are constrained and the theatre times are constrained, you therefore have wait lists. You have to ration care somehow, either through prices or wait lists. If you only have a public sector, you do it through the wait list. The Canby Surgery said that if you had a private sector which went in parallel to the public sector, that would alleviate some of the wait times for individuals in the public sector, and that would then allow them to provide good health, to the Canadian population. Now, as I said, and as the others have said, there's no empirical evidence, but that's because the empirical evidence about the alleviation of wait times is difficult to come about, because not only does the public sector necessarily get alleviated if the wait times go down and you don't have any capacity build in the public sector, but there's also a growth in demand for healthcare generally because there's capacity to take it. So two things are happening. Wait lists may go down, but overall demand goes up, in which case the wait lists may not change at all in the public sector because you're alleviating it, but you're operating with the same number of theatres. Now, there is another thing that Colleen said, which I think is important. One of the big problems is it's the same staff operating in both sites. So, for example, when the Blair government was in power in the UK, they said that the staff could operate, public staff could operate in the private sector, but only if they had already provided 4 hours overtime to the public sector first. So it's very important to regulate how staff move across two sectors if you have two sectors. The last thing I'd say is that, not directly relevant to this case, but to the NHS just now in trying to respond to COVID, the NHS is actually purchasing capacity off the private sector to try to get its wait times down. And that's exactly what happened in 2008 to 2016 that Sara talked about as well, where the wait times were coming down. They were coming down partly because the NHS had a contract with private providers.
Okay, let me pursue that with Sara. Do you think, Sara, we could make the same kind of arrangement here, whereby if doctors and nurses or whatever wanted to work in this parallel private, for-profit, perhaps better paying system, that could be allowed to happen, provided that medical practitioners commit to providing X number of hours to the public system, doing X number of procedures and so on?
Yeah, well, it's a great question because it comes down to, what are the rules that we're currently operating under and what are the sort of objectives of Canadian health policy? And so we can look to the Canada Health Act, which in 1984 sort of lays out what is the framework that the health system is organized around. And one of the first statements you'll read is that the Canadian health policy is, aiming to ensure equity in access to care. So ensuring reasonable access to health services that are medically necessary on uniform terms and conditions. this was agreed upon across all governments. And so this idea of uniform conditions is pretty rare internationally. And we're actually the envy of many countries in terms of being able to achieve this, where if we do want to preserve this goal of uniformity in terms of access, then we couldn't then at the same time allow people to pay who, wealthier and those who have the means to pay for faster care at the, potentially at the expense of longer wait times in the public system. If we were to assume that there's no increase in capacity of physicians and nurses and beds in order to ensure that the capacity in the public system maintains. So we should really think collectively, if we want to maintain this goal of equity and uniformity of access, then this model wouldn't work. But if we want to overturn that legislation and really rethink and fundamentally blow up that system, then all the regulations that Alistair started to list we would need to think through very carefully.
All right, I take your point.
That's a great.
Sorry, Alistair, go ahead.
It's a great principle, but it's not happening as we speak, is it? I mean, different provinces have different wait times, so they don't have the same uniformity of access as we speak. And that was prior to the COVID pandemic as well. It's worsened because of the pandemic. So it's a great principle, but the practicality is that you've got this postcode lottery in terms of elective surgery, at least as to where you live in Canada, as to whether or not you're getting access at the same rate.
Well, let me talk practicalities with Colleen Flood here for a second, because many years ago, of course you will remember, there was the Shuili case in Quebec, and the problem there was that the courts ruled that Mr. Shuili could seek medical treatment in a private, parallel, for-profit system if the public system was unable to deal with his issues in a timely fashion. What has been the impact, do you think, of that decision over these intervening years?
Well, I'd just actually like to go back and answer the question that was asked before about whether two-tier healthcare will make a difference. And this, with respect to Alistair, I mean, I'm originally from New Zealand, and in both jurisdictions, before the advent of wait time guarantees, both countries had two-tier healthcare systems, and both struggled with enormously long wait times, far longer at that point in time than what Canada is working with. So the argument that ipso facto, therefore, if we slap in a parallel private healthcare system into Canada, it's just as likely to go very badly unless and until all these other measures that Alistair is discussing come to pass. And we really do have to be quite careful when we go jurisdiction shopping, like, oh, I like the French healthcare system, vive la France, let's bang it down here. It doesn't work like that. So, for example, in Canada, our doctors are paid on a fee-for-service basis mostly. They're not employees of the state in the same way that they are in the UK. And they haven't, had contracts imposed on them in the past. It would be politically really difficult to try to mimic the NHS style system here. So we just have to be really cautious about this, hopping around.
Let me give Alistair a chance to respond to that, and then I am determined to come back to the Quebec case, the Shuili case. Go ahead, Alistair.
I agree. I don't think there's any easy solution, but I wouldn't go for a dominant ideology if it's not working. And I'm not defending the private sector at all here, but I just think that a predominantly public sector is kind of ruthless in the sense that it says if you don't need, you can't have immediately, or you have blocks on your access. So I think some alleviation of the public sector may be appropriate, but ultimately that's a political decision which would reflect the preferences of the Canadian population. And I'm certainly not going to tell any Canadians what to do.
All right. Sarah, maybe I can get you to come in here on the Shuili case, because what emerged from that case was the very strong signal sent by the court that if the Canadian Medicare system can't get people timely treatment to help their ailments, then it is legitimate for them to look to a different system to try to get timely treatment. What has been the impact of that decision over the years?
Well, it's a great question. At the time, there was this kind of shock. Like, is this going to increase the, options in the private sector? Are we going to have a sort of escalation in growth in the private health insurance market? And what we saw is that there wasn't much of a change. And on the sort of positive side, the government was really motivated to make some of these improvements that we're talking about. And I fully agree that we have constraints, we ration care based on wait lists, and that these wait lists are too long. But the government in Quebec decided to, use this, this court case to actually make improvements to and set these benchmarks for what is a reasonable wait time for the priority procedures in the province. And in the combination of, ensuring these targets that were met, as well as the fact that physicians really didn't have the opportunity to work in both sectors. There's still other rules constraining physician behavior in Quebec, like in other provinces, that Alistair mentioned earlier around, you can't work in both the public system and the private system simultaneously. Those rules remained in place. And so we didn't see a huge escalation in private health insurance or in private parallel practice in that province. And so it's really interesting that it shows us that maybe we can address the problem of wait times with the currently publicly funded system, and prevent the kind of escalation of private insurance that many other governments across the world are trying to contain, and look to Canada to see what are the rules that we have in place that help us to maintain and protect the public system without allowing a growth of private health insurance that does tend to undermine equity goals. If we do have equity goals, then these might be worth maintaining. So it's a really interesting question. And in fact, in the Swedish government recently invited us to come and talk to them to say, how do we prevent the private health insurance from growing beyond, they're at about 2% of the population. They're worried that it's growing too high. How does Canada maintain this distinction? And wanted to learn about the context here because it was lauded as an exemplar.
I've still got a lot.
Really interesting to learn.
Forgive me, I still got a lot to get to here, but Colleen, I want a quick response from you, if I can, on the impact of the Shuili case and whether it had the both feared and/or other consequences that many wondered about.
It didn't result in the unbundling of or significant growth of a two-tier healthcare system in Quebec because of an adroit response by the Premier at the time to introduce wait time guarantees, as Sara just said. But I think normatively it's had a big impact because, a bare majority of the Supreme Court indicated that, perhaps two-tier healthcare is some kind of an option. The devil's a lot in the detail. It was really a small challenge to the law that prohibits the purchase of private health insurance. Following on its heels, the much bigger challenge has been underway in the Canby case that Alistair is a witness in. And they're challenging all the rules. So the rules that stop doctors working in both public and private. It's a little unclear, but at first they were also challenging the rules that stop doctors billing above the amount that they are paid by the public system, the extra billing, and the private health insurance rules. So they're really going for the big kahuna, if you like, trying to knock over everything. And what the effect of that would be possibly chaos. And it would depend on the political stripe, probably, of the government in charge when, were that case to be successful. What would they do? Would they do as Quebec did and try to protect the public healthcare system? Or would they say, yee-haw, let's let her rip, and we don't really like equality and equity and access anyway. We'd prefer the rich to have more. So it's a chaos kind of strategy.
I think I see Alistair trying to jump in on that. Alistair, did you want a word?
Well, I don't think it's all or nothing, right? You can have mediated extremes, and you can. I'm not saying it's not complex, but you're not going to have. You're absolutely right to pitch it as equity versus some form of enhanced choice and access. And it is true that the private health insurance would probably be taken up by the wealthier rather than the poorer in society for obvious reasons. But it could be progressive. If you've got a progressive tax system, you don't allow people to opt out of the tax system. And so the wealthy, if they wanted private health insurance, would pay twice. It could be a very progressive system. You would have to regulate the medics and the healthcare workers so that it's not costless. But I don't think it's an all or nothing choice. I think it's more complex than that. And what you've got just now is you're not facing up to any trade-offs between equity concerns, efficiency concerns, and choice of provider. And that's really what you want to face up to. If you really want equity just to win all the time, then that's fine. But you have to face the consequences, long waiting lists, maybe low pay for the providers, provider migration, that sort of stuff. But everything has some kind of cost.
Of course it does, but that's not what the case is about. The case isn't about, let's pick, some sort of idealized model of a two-tier healthcare system and what we have now. That's not what it's about. It's about knocking down all these laws. And as I said, it will depend very much on the political stripe of the government that is in power when that challenge, if it is ultimately successful, happens. And as Sara said, what we saw in Quebec was that it didn't end up being so bad because of the way that the Quebec government at the time responded, which was basically to button down on the public healthcare system and introduce wait time guarantees. There is just no doubt in my mind that that would not happen right now if this challenge was successful in Alberta. The shhuili judgment was limited to the province of Quebec because it was a judgment that was successful only under the Quebec Charter of Rights and Freedoms. This challenge that is happening in BC is under the Canadian Charter of Rights and Freedoms. So if they're successful, this would apply across all provinces. And as I said, I think the outcome would be disastrous in many places. And there may be some provinces that respond. But I think what we need to do is really to fix the problem of wait times. And I think, as Sara mentioned, the Canada Health Act, it is beyond time that the federal government started to demand of the provinces.
Well, let me jump in on that, if I can, because we're literally down to our last couple of minutes here. And Sara, we've talked a lot about equal access. We've talked a lot about universality. One word, and I don't think it's in the Canada Health Act, one word we haven't talked about here is quality and ensuring that quality is supreme. Does the Canada Health Act need to be changed in order to make a greater commitment to that, in your view, Sara?
I think the federal government in Canada has huge capacity with its spending power to make a big difference in healthcare systems in Canada, whether it's through revising the Canada Health Act or simply through bilateral agreements where we're going to spend more as the federal government to support provincial health systems, but there's strings attached and it involves quality, it involves monitoring, involves wait time guarantees and other measures of quality. And I think there's a huge opportunity for federal government to work with the provinces to make those sort of agreements, whether it's through Canada Health Act or just using its spending power. I think that's a promising way out of this crisis.
Let me give our last word here to our friend from the UK and ask him, Alistair, you want to give us some advice on what path you think we should proceed on?
Well, I think, let me go back to what I first said. I think that public funding is the mainstay here. You have to have coverage for everybody. There can't be any exclusions, and you have to provide financial security for everyone with the funding of healthcare through the public sector. That said, we have wait time guarantees in the NHS, 18 weeks from referral letter to elective surgery being undertaken, 4 weeks for cancer. Even before COVID, they were all smashed. They were all broken. We have 2/3 of our hospitals which are running towards financial deficit. And that all goes back to the overall budget cap that the public sector has. And as was set out by Sara, that's a kind of trade-off that you're going to have to face. Either you accept some of these things, that you're going to have wait time guarantees, which will lengthen over time unless more money is put into the public sector versus uphold the principle of equity. And they're not easy choices. I'm not saying anything's easy here. I'm not saying it's easy for Canadians like everybody else. It's just not easy.
That's for sure. I want to thank the three of you for coming on to TVO tonight and laying out the options for us and discussing them so intelligently. Alistair McGuire from the London School of Economics, Colleen Flood from the University of Ottawa, Sara Allin from the University of Toronto. Great to have you all with us tonight. Thanks so much.
The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.